Hi, this is Elliot Fishman, and welcome to our latest vodcast. And this is going to be the role of cinematic rendering in the evaluation of complex vascular injuries of the lower extremity, how we do it. It's an exciting topic, it's a cutting-edge topic, and a really good article by Carolina Lugo and Elliot Lugo. It was just published about a month ago in Emergency Radiology. You can find more details in that article. But let me tell you a little bit about how we think about the process, how we do the process, and why it has significant advantages over classic ways of doing things in terms of trauma. So the objectives of this talk will be thinking about some of the things. Vascular injuries account for about 1% of all traumatic injuries to the extremities. Cinematic rendering can play an important role in the diagnosis and management of lower extremity vascular injuries by providing remarkable amount of 3D anatomic detail. Just to be clear, we've published articles in the past on volume rendering probably more than a decade ago. 3D in general, and as we've gone from the classic 3D to volume rendering, now to cinematic rendering, the application has always been there. It's just that we can give more detail. Radiologists should be familiar with protocol design and interpretation. And the purpose of this exhibit and the purpose of this talk was to provide an overview how CR protocol design aids in diagnosis of lower extremity vascular injury, the importance of CR for accurate depiction of the non-vascular structures as well, be it the bone, the muscle, or soft tissues. We talk about the range of acute traumatic injuries. We talk about the role of CR in treatment planning following the diagnosis of injury, and we talk about potentially some of the limitations and perhaps where things are going. I wonder long term, and I am not going to discuss it except for these 10 seconds where I'll mention it, things like the new Apple headset, the HoloLens by Microsoft, those may all prove to be very valuable in understanding injuries and perhaps in the future taking the imaging into the OR suite. Now, when you talk about vascular injuries to the lower extremity, it's one of the most common injury patterns seen in emergency medical and surgical practice. They are the most common reason for hospitalizations after a non-fatal trauma. Most severe extremity injuries in civilians are due to blunt trauma, but about 12% of civilian extremity injuries are a result of penetrating trauma or combined mechanisms. Particularly if you're in an inner city hospital, a lot of the trauma we see is gunshot wound related. Common causes of civilian lower extremity injuries include falls, industrial or work-related accidents, and of course motor vehicle accidents. The risk of vascular injury increases with increased injury severity, and vascular injuries occur in less than 1% of all civilian fractures. A 5-year retrospective review showed that 43% of patients with arterial injury had concomitant bony injury. So I think the point is, even with gunshot wounds, even with stab wounds, but especially gunshot wounds, you may see very impressive bony injury, a comminuted fracture of the femur with multiple fragments, or a tibia-fibula injury, and you say, boy, this patient must have vascular injury. But with good CT angiography, you can see no evidence of injury. You see the vessels are intact. So again, there's no one-to-one correlation between the two. In terms of management, we talk about hard versus soft signs of vascular injury. Hard signs diminish or absent pulses, active extravasation, a large expanding or pulsatile hematoma, Bruy, thriller, distal ischemia, and of course those patients get operative management. Some of the soft signs, a small but stable hematoma, unexplained hypotension, proximity of injury to a major vessel. The incidence of arterial injury in patients with soft signs is between 3 and 25%. Stable patients with an abnormal physical exam go to CT. CT becomes a critical factor in determining management of these patients. And CT with 3D reconstructions is between 90 and 100% sensitive in the diagnosis of vascular injuries. Now, If you ask me when do I have a problem excluding vascular injury, well, one is patient-related and trauma-related. Sometimes you don't see extravasation, but you don't see the vessel fully opacified because there's spasm present. So that can be a challenge. Sometimes there's motion, patient motion, poor patient positioning. Lots of artifact from bullet fragments can cause problems. So sometimes you're just not going to be able to make a specific diagnosis just because the study has select limitations. Now, there are different algorithms. This is an algorithm from the Western Trauma Association in this article by Feliciano. And I won't go through it, but you can see how imaging is a central component of what we do, particularly CT angiography, and how that decides specifically how the patients will be triaged. Now, in terms of imaging, imaging is everything. Standard axial, coronal, and sagittal images are generated at the scanner. Real-time volumetric post-processing is performed, typically on an independent workstation. MPR, MIP, 3D volume, and cinematic rendering can all be done. Interactivity, I find, is critical. You really can answer specific questions when you're doing the rendering yourself. Obviously, the post-processing requires no additional radiation to the patient. We acquire the data specifically with protocols, 0.75 millimeters every 0.5. So we have isotropic data sets. And so no matter how we look at the images, we have quality data. From the technologist's perspective, you want to position the patient comfortably. If they can't lay flat, let them lay on the right side or left side. What you really don't want is motion during the study. Motion will cause problems. As long as the patient is still, the study will be excellent. And of course, with cinematic rendering, we have the advantage when we look at the images of looking at the bony fractures, looking at vascular injury, looking at soft tissue, be it the soft tissues, the subcutaneous fat, the muscle, or anything else in between. Now, in terms of cinematic rendering protocol design, we have presets that we use routinely for bone, vessel, and muscle, but we can adjust them depending on patient size and often the noise level on the patient's images. Again, 0.75 millimeter thick sections at 0.5 millimeter intervals works very nicely. In terms of IV contrast, we like to inject at 5 cc's a second. Sometimes you can get by with 100 cc's if you're only doing part of an extremity and the study is only the extremity. A lot of times we'll do patients sort of whole body CT, so there the 120 CT is necessary as you're doing chest, abdomen, pelvis, and runoff all at the same time. Bolus tracking is ideal. Typically about a 230 Hounsfield unit mark is when the scans will indeed start. And again, one important thing to understand is the anatomy. Here's just a good look at the superficial femoral artery, to the popliteal artery, to the trifurcation vessels. So again, you want to know your anatomy. You want to know your variations, particularly in things like the trifurcation vessels. And you want to be able to really look carefully and understand specifically what is going on. Now, when you talk about active extravasation, and here's just a nice view of a complete vessel wall rupture with arterial contrast extravasation and hematoma, we talk about disruption of all layers of the vessel wall, which causes contrast to escape through the injured vessel. MIP has been the standard, and MIP is still very good at showing you the presence of bleed or disruption in vessels. Classic pattern being a jet or focal area of hypoattenuation within a hematoma. Sometimes you can see it best on the early phase and sometimes even a little bit better on later phase imaging. Cinematic reconstructions optimally can be done to define the bone, the soft tissue, as well as the vessels. What we'll often do when we're doing the CT angiography component you'll remove the bone. So one of the things that can be very helpful for bone removal is to acquire the imaging with dual energy. Then it's very easy to remove bone. And again, removing bone is very important. You want to be very careful, particularly when you have contrast extravasation, that the computer doesn't confuse contrast with bone and remove the contrast. So regardless of how you do the study, you always need also to look at the native vessels. So let's look at some cases. This is a patient, 13-year-old boy, who hit a metal guardrail while traveling downhill on his bicycle. CTA of the lower extremity, as we'll look at, will show a fracture of the distal femur with extension into the physis, avulsion fractures of the patella, and arterial extravasation superior lateral to the patella, and the patient was taken to the OR. Just a really nice example. You can see on the coronal images the disruption of the femur. You kind of recognize there probably is going to be vascular injury. You can see that much better as you go to the next three images. Three very nice cinematic rendered images showing you the bony injury, showing you the open wound, and showing you the vessel and contrast extravasation. I think that the ability to look at skin and muscle is particularly impressive with cinematic rendering and becomes a very important component, and this case is a very nice example of that. Here's another case in a patient with right anterior thigh pain and swelling after a fall down the stairs. The CTA of the lower extremity showed a large hematoma in the anterior compartment of the upper to mid thigh, with numerous foci of vascular blush appearing to originate from branches of the SFA. And again, this was eventually embolized. You can see on the images on your left, we remove the bone. So you can see on the cinematic or the volume rendering the active extravasation. You can see it particularly as we look at the middle image, which is very nicely showing you the bone, which is intact, and then the vessel extravasation, which is also nicely shown in the MIP imaging. Although I like cinematic rendering, I still will routinely do MIP on all vascular injuries. I think MIP is particularly good at looking at very subtle sites of extravasation. As commented, peeling away the sagittal views of overlying soft tissue demonstrates nicely the site of active extravasation in the musculature. The fine detail of bone allows us to rule out even the most subtle of fractures. So again, nice example showing you soft tissue, showing you vessel, and showing you bone, and the value of cinematic rendering, but also the fact that MIP imaging is something we will be using. Another case. 32-year-old presented to the ED with multiple gunshot wounds, chest, scapula, arm, calf, shin, and these are the ones where we do these whole body scans. Unfortunately, in major cities like Baltimore, these injuries are all too common. What this study does show is active extravasation from the descending ramus of the lateral circumflex artery, from the third perforating artery, and from branches of the infrageniculate popliteal artery. So again, this case also reinforces something we all know in radiology in general, the importance of looking beyond one finding. You found one site of bleeding, you say, okay, the patient's bleeding, next case, but you got to keep looking because there are multiple sites of bleeding. Again, a combination of the MIP imaging, the cinematic rendering showing you the vessels and bone, and the cinematic rendering showing you the active extravasation and accentuated for muscle. Again, just very nicely, and of course, I'm showing you static images, but you can do all this interactively on the computer. Very, very nicely showing you the patient's injury, particularly nicely shown the bleed from the popliteal artery, and with the associated muscle injury at that point as well. Another case, femoral fracture with transection of the SFA. It's a 20-year-old, came to the ED, had gunshot wounds to the lower extremity, symptoms, leg pain, diminished sensation and motor strength, CT of the abdomen with bilateral runoff studies, showed transection of the left FSA at the mid-thigh with active extravasation and a femur fracture. Patient was taken immediately to surgery. Again, one of the important things we can't overemphasize, but all of you know this, is triage is everything. CT has changed trauma. And this is a 40-year-old story, of course. Whether it's liver, spleen, chest, aorta, musculoskeletal, CT is what determines, for the most part, when patients do or do not go to surgery. Here you can see classic volume rendering on the left, and then two cinematic renderings showing you the spiral fracture, showing you the vascular injury. And again, the automated removal of the vasculature provides the ability to get a really good look at the patient's bone and the angulation of the fracture fragment. So again, you can do predetermined or predefined 3D reconstructions. People will often do this with 3D labs, and I think that it works out well in most cases or in many cases, but I think the ability to create select 3D images becomes very, very important, and that's why the radiologist needs to be involved. I think the techs can do a great job, but the radiologists who know and understand what you're looking for. Also, we find that the referring docs, particularly the orthopedic surgeons or vascular surgeons, like to look at the images themselves as well. So let's do this. Let's stop here, and then we'll come back with part 2 and look at another 7 cases that show you some of the highlights of why cinematic rendering is so important. I'll see you in a few minutes. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.